So I am really excited about this next panel, which is titled Bold Horizons, the Future of Health Information Exchange. We have Kahn from McKinsey and formerly from CMS that has done a lot of work with HIEs across the country that's joining us to moderate. And then we have a whole panel of HIE leaders, including international representation. So really excited about the session today, and I'll just turn it over to Jess to get us started.
Thank you,
That's
Melissa.
what we were looking for.
Okay, so we promised we would keep this lively so that you don't have your post-lunch lull. And if any of you have ever seen these folks on the stage before, you know I don't have to say much to get them to go. But I'm gonna introduce them just in case, and then we're gonna jump right in. So hold on to your seats. So to my left, I have David Horrocks, who is not with CRISP, in case you weren't paying attention. He is now the CEO of the New York eHealth Collaborative. So welcome to David. And Robert Denson, he's the acting CEO of Malaffi in Abu Dhabi, representing ex-US perspective on HIE. And then we have John Kansky from the Indiana Health Information Exchange, and Jaime Bland from CyncHealth, which is Nebraska and Iowa. So it's quite the illustrious crew. So consistent with the title, and we thought we would ask them for their thoughts, not just from their own experience and where they're working, but as part of the industry and as engaged as they are in national conversations as well. So I'm going to ask a question. We can kind of go down, but also feel free to jump in if you would. So thinking a little bit about this morning, we talked about Medicaid and public health and behavioral health. How could state governments use health information exchanges, the noun, or data exchange, the verb, to better improve Medicaid and public health? And you can answer that for countries instead of for states. And you don't have to say Medicaid, you can just say public health. How does that work?
Sure. Just
You wanna go
I
first?
think that, well, you did say, you sort of pointed this
Yes.
direction. I
Yes.
didn't mean to
You go
jump
first.
jump
No,
at
you're-
you.
I was
you're-
waiting
Go
for you to
first.
I think that health information exchange is very much becoming public health infrastructure, and that many of the new things that we have done have a public health impact. If that wasn't true before the pandemic, it certainly is true in the response to the pandemic. So I think that states understanding how to leverage this health interoperability infrastructure to promote public health causes is really important. And as part of that, I do think that states are increasingly putting energy into getting completeness of data for the state. And they're doing this in a variety of ways with incentives or with mandates. They are moving increasingly, I'd also say, to a sort of single statewide utility to manage HIE services. And it's because you need that completeness of data to serve some of these public health purposes.
What about Medicaid?
Well, Medicaid, I get corrected once in a while when I don't include Medicaid in public health. Medicaid is a public health program.
I know, but they have different funding and different bosses. And
Well, in our state, it's two different agencies.
There you
So,
go.
yeah, my answer's pre-bifurcated, but
yeah,
No, go ahead.
that was my jumping in.
Yeah.
I love it. Go for it.
Yeah.
Then we're going to come back to you, Robert.
So we're all kind of biased by the states in which we operate, and there's different. The current state varies quite a bit in terms of how much one organization's cooperating or supporting Medicaid or public health. As I said, in our state, it's two different agencies. I asked my team. I said, I'm going to be on this panel. I'm going to be asked a question about how we support Medicaid and public health, or how we ideally could. And I said, give me some stuff to talk about. And I got this document that they use with our state that has 22 different use cases and projects that are ongoing. So, and that's not to say that we're on the top of that pile by any means. I think all these organizations are represented on the stage are doing a lot, but David mentioned a single statewide utility, and I think that is the future approach that's going to make the most sense. the T-shirt slogan is that every state should have a statewide health data utility. And it would, in my view, doesn't matter if you've got 2 agencies or 1 in your state. There should be that function that could meet all those needs from one place. As long as we've been in the HIE business, there's always been all those use cases laying there, all those value propositions, I should say, laying there that we could be working on with our state government. And I think the pandemic on the public health side really was activation energy to make a lot of those things either happen or push, in our experience, push forward the relationship that they can now happen. And Medicaid in our state, kind of a separate thing, is on the coattails, I think, of the activity that was spawned by the pandemic.
I know Contexture's not up on the stage, but they do have a page I noticed in their fancy packets exactly on this topic. Go, Melissa. So you can hear more about that. Do you want to give us a perspective from a countrywide perspective? How does HIE help public health?
Very similarly. Early on, I wouldn't have said that HIE was necessarily a critical piece of the infrastructure. Pandemic obviously changed that. So much so in our region, all of the lab data would go to an application for people to enter in malls and restaurants and be able to travel. And so if there was any sort of slightest outage, we heard about it, right? Because people couldn't go about their normal day-to-day. So being part of the infrastructure, I think, is really key. And even the Department of Health mandated when people were going to administer PCR tests or vaccines, we were the last approval to make sure that they could send us the data in the way that was supposed to be structured to be able to facilitate reporting to the public health center, and then also, to send it to the app that can, people can move around in the community. So I believe fully that it should be part of the infrastructure. The other areas that I think are a bit missing still, and we're still building this relationship, but the knowledge centers, I believe HIEs truly are the clinical data knowledge centers. So how can you facilitate that within the regulators, whether it's public health or Medicaid offices, to drive disease registries or all the other programs? They're the clinical data experts, and so they need to be integral into those conversations, and even probably the technology piece to facilitate that exchange. Otherwise, I think they're just duplicating the spend.
Mm-hmm.
Yeah, and just very tactically for Medicaid, I think that, the continuity of care, the care coordination, all of those things that are probably in your use case library is definitely one of the largest value propositions that, we work with the various MCOs. And if you think about, the plan change from year to year and not having that information and then expecting to get the care gaps done, we should also probably caveat that where you live, there's no HIPAA law. So don't let anything he says scare you. That's just the, not HIPAA is not global.
Yeah.
So, but I think that's, having that look back period for Medicaid has been a big value proposition. And then from a public health perspective, we can name all of the disease registry, contact tracing, ECR, but it's actually just very, the contacting of people for the follow-up of, care or understanding what, long COVID looks like. That's the kind of infrastructure development that in modernization that's so important for the work that we do.
Right, that master person index is a huge resource. One of my favorite Medicaid use cases that I've heard, I think, is actually from Contexture, and it's for people to qualify for non-Magi Medicaid, right, based on disability status, which you have to show clinical proof for that. And that's usually takes weeks because the patient, who, by the way, is the one who's age-blind disabled, has the burden of going and finding that information and providing it, and it has to be validated. So that's a role that HIE can facilitate, not just because it's a trusted and complete data source, but the speed that can lend towards eligibility processing I find really intriguing. I've always been a big proponent of these use cases being the non-sexy administrative ones, not just so they can go to the mall and travel with their vaccine credential. I mean, that's great, but I also think like we're not always going to be in a pandemic, knock wood. And so like what are the ways that Medicaid and public health can use HIE for their core, everyday administrative functions, validating identity, those kinds of things that need to happen, right?
And I think what the pandemic highlighted for us, and I think Morgan talked about earlier, is all of those human service agency use cases like WIC, like foster care, like justice-involved youth, that they need information to follow them too, and what kinds of data governance infrastructure that's needed between public and private partnerships to really facilitate that information exchange.
And to achieve that ideal where I have to air quote the health information exchange, that's the word everybody here knows, but really where we're talking about the emerging term of health data utility, which is much broader in its implications. And I noticed on the slides that Melissa and Morgan were presenting on the status of contexture, you had like 5 or 6 boxes on the bottom of your slide, and the first one was health information exchange. Well, there was like 5 other boxes on that slide. You're already doing things that a health data utility would do. But there's almost an endless, if you think about the things that are done in a state in the public and private sector that require secure, curated health data, you can go in so many directions, but it's necessary to have that the state agencies need to understand that potential value proposition. The health data utility has to be prepared to execute on those value propositions,
Right.
and then you have to have the relationship bringing those things together.
Right. It's not an environment that enjoys risk. So I think that's an important part about being able to execute, not overpromising. So Jaime, you raised human services, so I'll pull that thread. In your view, all of you, what is the ideal way for clinical data, claims data, social care data, and other data to come together to improve outcomes? And what's the role of agencies, entities such as yourselves, how's that, John, to play in facilitating the mashup of all of those data types?
Well, in Nebraska, we have policy and statute that facilitates the linkage of data across those disparate data sources. So we have HIE, we have PDMP, we have claims data, we have the community information exchange, and other referential data sources to build the longitudinal health record. And that foundation is the master patient index, and really the foundation of what we in Nebraska call the health data utility. In Iowa, that's facilitated through Medicaid regulation and or through HHS regulation, I should say. And in that regulation, the master patient index, privacy, security, all of that requires a governance infrastructure. In Nebraska, we actually have statutorily a Nebraska Health Information Technology Board, in which a lot of that data governance is discussed, and that's a public meeting that anybody can attend. We've only had a couple of outsiders want to attend, but
Sounds like an invitation. Just saying.
if you want the Zoom link, I can send it out. It's not as lively as some school board meetings or anything like that, but it's a way for us to communicate with policymakers around transparency, around governance and responsibility and transparency and trust. And I think that one thing that health information exchanges and health data utilities kind of trade on is that trust relationship, whether it be relationship trust, functional trust, or value proposition trust. All of that in that paradigm is really where we're able to ingest different types of information, package and curate those, and then send them out as different value propositions.
I think that the oversight and data use, such as you were describing in those 2 states, Jaime, is an important piece of the picture here. When you combine data, you enhance data. And so putting these various data sets together, whether it's social factor data, clinical data, enrollment data, the resulting output is more powerful. But who do you trust to hold all of that sensitive information, whether it's health information or social information or other things? And I believe a health data utility, to which there is oversight, there's community engagement and appropriate uses of data, there's regulation, are uniquely well positioned to do that. And do we trust the government to hold all of that data? No, we probably don't. Do we trust Palantir or Google? Maybe we don't trust them either. But these health data utilities, which have that oversight and community involvement, I do believe are uniquely well positioned to play that role.
And are nonprofit.
Yes.
Right, so
yes.
there's the mission-driven.
Yeah.
I was talking to a public health data leader recently, and she was telling me that she wants claims data, right? So this is someone who has the richness of all the registry and the lab, whatever. She wants claims data. She wants to see the pattern of utilization, and she wants to understand where people are getting care for which conditions, and she wants to be able to use the claims data. And so she was like, we should create an all-payer claims database in our state. Okay, so let's not get to the who yet. Let's just get to the how, and think about the how, and not saying good, bad, or ugly on ends up who ends up being. But I think the point is there's still a lot of hunger within state agencies for each other's data.
Yeah, and in so many cases, they can use limited data sets to answer the questions that they're trying to address without having to compile all of that sensitive data, all the identified data. But you do need the identified data for the matching, for the combining.
Yeah.
So it's so powerful, but I really do believe health data utilities are best positioned to play that role.
If you have whether you're asking about outcomes for Medicaid members or public health or the payer's needs or employer's needs or provider's needs, there's things you can't do without that unified, combined data asset. And just to offer one specific example, which I think some of us lived through and are living through, and spawned by the pandemic, and is race, ethnicity, and language data. It's like the HIE tends to be the organization that has data from so many sources and can serve as the best source of truth that you have, whether it be for an individual or a population, to enhance. Anytime you're asking a question about race, ethnicity, or language, the HIE is probably a source to enhance whatever data you're analyzing.
And it still comes back to the governance question that Jaime had, which is the most recent data that you would choose? Which of all the data sources that include SOGI data that an HIE has, which would you prioritize and trust the most? But by having community members, by having state government officials and others part of that conversation, then you can discuss the trade-offs and make a decision that everyone feels comfortable with.
Yeah, and I don't think you can get to the outcomes that you are looking for in any community without all three of those. And I think the HIE is at core to set up the unified data model because of the MPI layer. In my community, it's different. I don't have necessarily the same trust in government issues. Most people there, I think we did a YouGov survey early on, and 85% of the people trust the government. And so it's a very different interaction than my experience here in the United States. So we focus more on the technology than the policy side, and so we're really focused on the unified data model and how we can bring all those sources together and serve them up in an easy format for each of the departments to get to the outcomes they're looking for.
It's an important reminder, right? Of all the different approaches people could take and all the flavors of health information exchange, the context that they sit in matters a lot.
It does.
It's important to think about that. So let's think about the horizon part of our session title here. We'll start with Jaime and come down. What's something that excites you about the national landscape in health information exchange, and something that worries you?
What excites me is I think we're finally having conversations about what a modern data infrastructure for the country should look like, and what are the multiple use cases for that. And from my perspective, I play an active role in the feds are going to do what the feds are going to do, but we're going to focus on, what policy in our state needs to look like. When I talk about the governance infrastructure, we want to use that for model policy, right? Like that's something that a number of states could adopt. We can, point to really good use cases that's provided trust building across different communities, and that's really, to restore that trust, right, in data is something that we're focusing on, and why we're pushing data down to community-based organizations. One of the things that, we're working with both some national partners out of HHS and local communities is maternal child health information and how we get that back to providers and into emergency rooms so that we can really look at maternal child health outcomes. Having the conversation about using our infrastructure to really look at long-term outcomes, and that's data-driven and it's real-time, and it's not looking at data from 3, 4, 5, 7 years ago. That's exciting. What scares me is that it could all change very quickly in an election cycle, right? And that's, I think, I'm going to let John talk more about this because I think he's got better details than I do. But like the implementation of TEFCA without having a lot of that fleshed out in public health use cases, and what about my rural providers, and what about my rural hospitals and critical access hospitals that are generally going to be disenfranchised by that policy. And I can start to list the ways that could happen, and it doesn't include EMS providers. I live in Nebraska, and we have frontier counties that a lot of the care provided to those folks that live in those counties is by community paramedicine. Again, going to be disenfranchised by TEFCA. So I think that's just a reality of, hey, I'm not a flyover state. Like stuff happens here that you need to understand at HHS. So you said bold, right?
Bold.
That means you have to come up with something nice to say. You have to say something positive.
Oh, I have all kinds of positive
Oh,
things to say.
Jaime.
Okay, so what I'm going to be hopefully, every time I say I'm going to be unusually concise, I go on for like 5 minutes, so I'm not going to say that. What excites me nationally is how much this concept of a health data utility has caught on and is getting socialized and is being implemented and enacted at state policies. That surprised me. What excites me in Indiana, which is specific to my context, is the positive trajectory that we have in relationships with key state agencies. And there's a lot of pent-up demand of things I think we can be doing to support state agencies that we're now have the relationship and the basis to perform on. What concerns me, Jaime kind of teed me up, is we have this federal policy, and we're going to be implementing TEFCA as a country. We're going to be implementing TEFCA as a country.
Are you convincing yourself or us?
It's kind of like it's going to happen. So my concern is that, so 21st Century Cures, the federal law that gave ONC the assignment to create a TEF and a CA, said, oh, by the way, whatever you do, don't disrupt current exchange. I feel that this they could have fulfilled their assignment in a less prescriptive way, because I don't know any way that this isn't going to be disruptive of current exchange, but we all have to figure out how to complement and fit into a world in which there's also a TEFCA laid on top of, next to, part of the ecosystem that existed before there was a TEFCA. I don't know if that made any sense to anybody who's not a total HIE TEFCA dork. Jay, you know what I'm talking about. So we're just gonna have to see. We're gonna have to make sure as leaders in our respective worlds that comes out in the best interest of patients, providers, public health, as the rubber hits the road.
All right, Robert?
I'm not usually concise, so I won't say that either. So, applying my experience now after, having worked here in the HIE space and moving to Abu Dhabi and building the HIE there. And the concept of health data utility obviously isn't something I deal with day in, day out, but it does liken a lot to our program where we were a public-private partnership, and quite frankly, I think it is extremely successful. So the Department of Health Abu Dhabi mandated all providers are obligated to participate in the health information exchange. So, we were able to connect. I think right now I have less than 50 small practices and standalone pharmacies that are not connected in less than 3.5 years. So you really get a breadth of data than when the HIE. So that really powers a lot of the use cases. And so for me, applying to the health data utility, I would be a big believer in these public-private partnerships and health data utilities, when the time comes to come back home. So those come together, and I think that's an exciting space, and I think there's a lot of opportunity there. And it's a different way of doing things and thinking about things, as Jaime said earlier. So I'm excited about that, and I think it's an extremely successful program. I'm also excited about, in our community, promise of analytics. So we've started presenting predictive analytics into the community, and in fact just released in June, where we have 11 risk factors that are presented on a patient level for every provider accesses our clinical portal. So that's really another tool for providers to use in the care of their patients. The other piece, which then also makes me extremely nervous, but we released the health portal just 2 weeks ago, so people can download it. If you're a citizen of Abu Dhabi, it connects to the national infrastructure for identity management. That's a digital identity management system, and so you can download and you can access all your records, no matter where you've been within the Emirate of Abu Dhabi, which also makes me extremely nervous because it will absolutely start to highlight the data quality issues, which I think we all understand that those are very, very real, and you can't hide behind them. But then the excitement also for me is also how that's going to drive improvements in that data quality as well, because now patients will be asking their providers for those corrections, right? So they're going to have to be a lot more diligent. So those go hand in hand, but it does make me extremely nervous.
Shining a light, yeah. All right, David.
Well, I'll also say I have an optimism about the national networks and just how much easier it is to move a clinical document from one place to another place, from one hospital to another hospital, and some of that is the great work that Jay does with his team over at the eHealth Exchange. I think Jay might have just slipped out. And
everybody tell him that we said
yes,
something nice.
tell him we did say nice things about him. And even the promise of TEFCA making that even more ubiquitous, some of this is because Epic has just become so dominant that moving things from one Epic shop to another Epic shop. So we should celebrate this. This is a good, positive thing that it's easy to get a medical history moved from one place to the other. So then what worries me is just the flip side of that some some of our national efforts, I worry, are at cross purposes with use of these infrastructures for public health reasons. If, for instance, hospital leaders feel like, well, I can get the discharge summary from across town now, I don't really need to participate in the HIE work. Well, now we lose the opportunity to be engaged in the public health purposes. We lose the opportunity to engage others in the community. We lose the opportunity to combine that hospital data with the social factor data, which we all know is so important. And I'm not convinced that the ubiquity of Epic is long run going to be great for us either. So, and then CDC is making national efforts to improve infrastructure, which is good and appropriate, but I worry it is, again, maybe at cross purposes to what we want to do at the state level. So I worry about those national directions being harmonized with the progress at the states.
You going to add on?
I want to add on is that the other thing I would add to what is that the answer to have we achieved interoperability is not the answer to the question, can I get the patient's data from over there to over here?
Yeah.
And too many times, and I don't know the organizations or roles in the room, but I'll pick on a hospital CIO who wants to be assured that they can get external data to their doctors or to their nurses at the point of care. But there's a question of quality and completeness and workflow that can we get the data from here to there is just the beginning. And so there's a danger in as we figure out how to have HIEs supporting the point of care with national networks supporting the point of care, or hopefully those two working in a complementary way, organizations have to take a deeper look at, are our clinicians, are our care managers getting high quality data the way that they need it? Is it complete, is it correct, and not just can we get it or can we not get it?
TEFCA is about one patient's data moving from one place to another. And I know that if you sort of read all the documents, they have aspirations to more, but that's really what they're trying to solve for. But population health is about data sets. It's about looking at trends. It's about combining things. So I think it's important to keep those two thoughts in our head at the same time.
It's a good frame. I'm going to use moderator's prerogative, even though it means Melissa might never ask me back. I'm going to answer the question too, which is, okay, so things I'm excited about. I'm excited that, and I know it's just one little teeny tiny thing, but you got to take your wins, y'all. I'm excited that my vaccine, my proof of vaccination is in my phone. How many people have their proof of vaccine in their phone? Okay, like for real. Pre-COVID, did you have proof of anything health-related in your phone? Right? Like not unless you took a picture of it. So like, and how many times have we tried that? There was health fault, like there have been lots of people who tried to make that happen and it did not happen. And so every time I have to like show it, it's, you know, like when you're like, well, let's just say at my age, it makes me happy when I get carded, right? Because I'm like, oh, sure, I'll show you my driver's license. Now I'm like, oh, you want to see my vaccine credential? And I like pull up my phone because I'm so excited to show people that I have it on my phone and not on that stupid piece of paper, which doesn't fit in a wallet, which was a total design failure. The thing I'm worried about is it is almost 2023, and we are still having the conversation about moving data, not using data, which I think is a little bit about where you were going. I don't care if data can move from point A to point B with rainbow colors in 2 minutes, 2 seconds, 1/10 of a second. If the people on the other end don't use it, if there aren't incentives for them to use it, if it is not easy for them to use, if there's not an expectation for them to use it, then what were we doing? Like, honestly. And so that worries me that we are still having this conversation about having better standards to move things from point A to point B. That is not helpful. It's just like 1963 thinking. Like I just, anyway. Okay, I actually have one more question, which I won't answer myself, which is, let's assume that Morgan and Melissa and folks do ask us back next year. What would we be talking about in terms of health information exchange? Like what's next year's hot topic? And dare I say it, like 5 years from now, what do we be talking about? And please don't say TEFCA or data exchange, interoperability, or any of those things that I just ranted about.
I'll start.
Okay.
You know, going to the point about moving data, you know, that's the basics, right, of HIE, and there's so much more. I'm a strong believer, especially now, you know, like in my community, and I know it's starting to move here, but patients getting access to information. And it's not just their healthcare data, it's so much more information. You know, I love using this analogy. You know, I search more for buying a TV, you know, the flat screen TV, than I do in my own healthcare and looking up doctors or whatever it may be, right? And so I think, and I really hope we're talking about consumerism of healthcare in 5 years from now. And I think, you know, this transparency of data will help drive that.
Well, in my state, in New York, we are working with CMS on an 1115 waiver, which would allow us to provide some very targeted social services as part of the Medicaid program. And this is happening all across the country, where we all understand that social factors or social determinants of health are very impactful in outcomes, and we want to have a more integrated delivery system. And because we are support organizations, we will end up supporting more of that activity. So I think that next year you'll hear a lot about use of HIE or health data utilities to support 1115 waivers, referrals to social service agencies, an integrated understanding of a person's situation. So I think that in the next year that will be a hot topic, because that's a hot topic in healthcare.
So are you writing these down? These are your sessions for next year. So we have consumer role in data and using their data, and we have the role of HIEs in 1115 waivers for improving use of social care. All right, John. What are we going to be talking about next year or 5 years from now?
One year feels like 3 weeks to me. 5 years is almost the easier question to answer, but so just mush these together. This is my 3-year answer.
Oh, fine.
I'd like to say that there'll be more state laws, state policy recognizing the kinds of concepts that we've been talking about, and having a statewide health data utility being an understood concept that's being encoded and implemented in a greater number of states. And playing a little bit off David's comments, I think social care will be more table stakes. I want to see not just us talking about moving data. It's like, hey, we're capturing social determinants in our database. Great. How is anybody applying that information to make anything better? And so I would hope that in 3 years that we'll have more examples of how social care is being implemented, and that those health data utilities are in the thick of things.
That would be a new set of providers or consumers as well, I would imagine, would be at the table then of that data.
Yeah.
Yeah.
Mm-hmm.
So if I'm back in a year, I hope that I would have at least 6 different publications that we're able to push out research use cases through our collaborative, which is an academic research-based organization that is part of our enterprise. But we've really been pushing the utilization of HIE data in those research use cases. And when we say HIE in my context, it is, and I really want to push this adoption, that it is health information exchange. It's not hospital information exchange, right? It is, that means when we talk about healthcare outside of the bricks and mortar of the hospital, that's health information. And that includes the clinical information we get from your standard EHR, right? And the community-based organization that produces information about housing and how housing impacts your health, right? And those are the kinds of things that we need to push out from an understanding perspective and help providers actually contextualize this information. How did I get to HIE? Because I'm a nurse, I did care coordination. I worked for the VA, which has an integrated record, right? And I was doing provider improvement, and we could look back in 30 years of history of information, but nobody did that, right? They wanted their reports, their curated reports, and I could look across the nation, and I could do a lot of things. And those curated reports are what changed practice, and that's those downstream things that we're working on. So the query platform has a use case. It has a use case for, you may have heard of a cyber attack that was recently in the news in the past couple of weeks. I will tell you that in the Omaha metro area, we were a redundant health information exchange. There was no diversion. There was no stoppage of surgical cases because we have a statewide health data utility which was used as a redundant system to continue care. So those are the kinds of tactical things that we need to be talking about when we're talking about health information exchange beyond this query.
You're like the generator that went on when the lights went out,
Yes.
when the electricity
Yep.
got cut out.
Analogy.
I'm going to work with you on how to frame this.
Yes.
Because
Okay.
that's a big deal. Like the hospital wouldn't have otherwise been able to provide care, do surgeries because their whole system was out.
Actually, you should have those people that were doing that work
Yeah.
come and talk about
That's
it
another
next
good
year.
panel.
Another panel,
Yeah.
there you go. Because that was like a real thing that they talked to the governor about and, was really impactful. But all these downstream use cases, and something that when you said about framing, a monopoly is not interoperability. So when we talk about, well, if everybody had Epic or if we were just on this national exchange, that is still not interoperability, right? And you told me not to say interoperability, but I just had to make that point because even if we take that out and say that that's already done, there's still so much. We onboarded 440 providers last year. I've been in operations for 15 years. We're still onboarding and onboarding and onboarding new information. And that's just regular EHR. That's not including the 1,300 community-based organizations that we onboarded. And, so there's still way too much work to do to get the full comprehensive longitudinal information. So the full comprehensive health picture is what I want to be talking about in a year. I think in 5 years we can talk about consumerism and consumer-mediated consent and how that plays into the infrastructure as well.
Jamie and I were talking about consumer-mediated consent yesterday on the way in the Uber on the way here. I thought that was fascinating. The director of the Behavioral Health Administration, who said quite the opposite, right? She said people in time of crisis shouldn't be expected to have to mediate access to their data, and that there should be some sort of safety net support and system for them, which just highlights for me that there's no one single answer for this, right? It's probably a hybrid of things that we need to offer.
So much of the arguments about interoperability in this country are fighting over the how.
Yeah.
Yeah, but I don't think we should be afraid of consumerism because I think this is like another VA story for me. So when we pushed behavioral health data into the VA patient portal, all the providers are like, that is going to be a disaster. It's so many complaints. We got like nothing. I think if you give people access to their information, they will be responsible with it. And if you write something in a record as a provider that you shouldn't have written in there, shame on you, right? So I totally trust people that they will access if they want to. We've had a patient portal for just over a year, and we've had like 300 people sign up. Now, it's not to the place where people are truly like shopping for care yet, but you have to start somewhere, and we started with kind of a low marketing investment in the patient portal until we figured out how to do consent, identity verification, all those things that you have to do. So
It's not easy.
it is not easy. No, it's not. It's totally
as
things
easy
you
as
got to
my
work out, bugs you got to work out.
My vaccine credential, it's not quite the same thing. So let's take some questions from folks other than myself. There are mics around. Uh-oh, here comes Morgan. Be nice now. We just teed up your whole agenda for next year.
We go way back, don't worry about it. She asked me if she needed me to lower the mic, just so everybody heard the joke. And yes, Christy, I did lower the mic. So what? So I'm going to be provocative here. I'm a healthcare provider. I'm a state agency. I'm a payer. I'm a primary care provider. I'm a hospital system. I mean, we've probably got people sitting from all of those different perspectives in the healthcare system in this room. Like, so what? I'm going to go back to my work tomorrow. I'm going to have to make my numbers. I'm going to have to see the 20 visits a day, or the X number of admissions, or the utilization reviews. I mean, one of the things that has, just to be transparent, one of the things that has shocked me kind of from my seat in the audience is that the lack of strategic use of the HIE, or the health data utility, by all of these different segments, when there's a little bit of a perception that, like, I've got my systems, I can do this myself. Like, so what? Like, all these folks in the room are going to go back to work tomorrow. What would you suggest that they think about, or what is the thing that they can take home, that all of us can take home, to say, we really haven't been using this thing to its fullest to make our life better tomorrow, to make our patients' life better tomorrow?
Oh, that's a high-level question, so I'm kind of going to give a high-level but maybe a little passionate answer. So when I was a young man, I went to school for biomedical engineering because I thought I was going to create, for Monty Python fans, the next machine that goes bing next to the patient at the bed, and that was going to save people's lives. And what I learned rather quickly was it was bad information, the lack of information that was harming people and populations. And so ask yourself, of the problems you have on your to-do list, probably your long-term to-do list, how many of those things could be improved or solved with more complete or better information? That's what we make it's just complicated and challenging in our complicated healthcare system. So we are the information people, and we're work with the organization in your state. I guess Colorado would be the answer. Work with Contexture on attacking your problems with information. And same thing I tell our customers in my own state is participate in our exchange and then kick our butts for whatever you need that we're not doing. Sorry, Melissa, but I'm encouraging you to kick your butts.
I have an answer. How many of those people in this room love reporting? Love reporting, come on. Like, it is why you got into medicine or into healthcare, was reporting. You don't I don't know who this gentleman is, but I'm gonna come find you after. Like this is like the best thing of being in healthcare is the reporting. How many people love duplicative reporting? Triplicate? See, he put his hand down. I had you at duplicative, right? So that's for me. I mean, I always give you the housekeeping example. Like, wouldn't you rather give your data once and have them do the reporting? Whoops, have them do the slicing and dicing and have them facilitate that? Or do you really want to have half your staff filling out forms and sending things to 100 different places for your quality measures, for your licensure, for your payments, for whatever it is? That is not what got you in this field. That's not what brought you into this room. And one of the things that these utilities do, I mean, that's the word utility, right? Util. It is meant to be functional, not just getting data to people, but also getting the data out in a way that's efficient and functional. So I would be asking your health data utility partners, help me streamline the amount of reporting. And I mean tactically, I have 6 people doing it, I want to get it to 3. Or it takes us 20 hours a week, I want to get it to 10. Set a goal and then go back and think about what your staff could be doing otherwise for patient care or for efficiency in your practice if they weren't spending all their time reporting except for him because he likes it, we want to keep him happy.
Well, I think just very tactically, I design systems and downstream reporting for every nightmare scenario I've lived in my life as a provider. I used to spend 40 hours a week tracking down mammograms and colonoscopies and last blood pressures, and I had a team of nurses guys that could be working in your clinical setting, hunting down that same information, because apparently it takes a bachelor's of science in nursing to find a colonoscopy exam in somebody's random imaging practice across town. So that kind of data gap, that's what your health information exchange can provide. Worked in an emergency room. Gosh, wouldn't it be nice to know somebody's medication history before they rolled up in your emergency room? Again, that's what we need to be asking from our health information exchanges, because I don't want that person coming back in 2 hours with an allergic reaction for the meds I just prescribed them, right? So that's a big win for providers. And I've been the person that needed to aggregate data on 30,000 members. That too is another aspect of how do we find data in aggregate from a population perspective, and then plan care management interventions for those population health related activities that we're responsible in deploying in a community. Also, having a place to refer somebody when you're the only provider left in your office at 4 p.m. on a Friday, and please don't answer yes to that question. we all don't want to ask at 4 p.m. on a Friday because nobody's open. I don't have a place to refer you. I'm going to have to send you to an emergency room. And we all know how that's going to work out, right? So those are the kinds of things that health information exchange as a health data utility can really make providers' lives better.
This, I'm not sure this is exactly the pragmatic answer that Morgan was looking for, but in New York State, we have regional HIEs, and the HIE in Buffalo, which is called Healthy Link, they did a study with some academic partners, and they looked at a shared savings program, and they built a four-part quadrant. I said that wrong. It's four-part quadrant is redundant, isn't it? So a 2x2 matrix,
Nice.
and
Nice.
and it had practices that participated in CPC Plus, which is the shared savings program, and those that did not. And then they had practices which routinely used the HIE, and then those that did not. And what they found, and it's intuitively what you'd expect, is that the quality measures they looked at really didn't move if you were in CPC Plus, but you didn't use the information available to you. And that having the information available without sort of the structure of motivation and the financial supports and so forth also didn't move the needle. It was the two together that resulted in improvements to the quality measures and actually reduced spending. So I do think we need to marry these infrastructures and capabilities with good program design and good health policy to get the value out of them.
And I'll expand on that just a little bit. I think, to the providers, information is money at the end of the day. And so, we've done a study, and it's not finalized yet. We hope to release it here in the fourth quarter. But we're seeing those providers that are using HIE are reducing costs by 24%. And we've only been live for just over 3 years. And this is combining claims information with the clinical access of the HIE. And so, that's a significant savings. And so right there, if you don't go home, thinking of that savings, then I think you're missing the boat by leveraging the HIE. And that's just from an information standpoint and basic data exchange accessing for, someone's health information. I'm a big believer that HIEs can support broader use cases around analytics. They're, as I said earlier, they're the experts in clinical data, and so leverage them for those analytics. I saw in Contexture's roadmap, analytics is going to be a big piece of your strategy moving forward, and I think it's extremely key to use, the provider should be using the HIE because you have a broad spectrum of that information, and you know how to massage that data in order to serve it up in the analytics realm practically and usable as well, which is a key issue that most have when they deal with clinical data. And then the last piece, and again, time is money and very pragmatic here, but I know providers that are saying to me right now, they're excited to market our health portal on behalf of us for adoption because they spend 30% of their time in certain business units just chasing down information to serve it back to patients. So, it's very practical in that answer, but again, time is money at the end of the day, and I think that's a key use for HIE no matter what region you're in.
Happy, Morgan? I don't want to see where to go. All right. So I think we are at time. What? We have 2 more minutes? 13. Oh, I was going to say that's dangerous. Okay, all right, fine. Other people have questions. Let's hear it.
Hi, Amy Crane, Diameter Health. And Jessica, I really loved the way you characterized TEFCA as still having a conversation about moving data rather than using data. So I really like that. Really done. So it started making me think about something else, which is FHIR. So I'm wondering what the panel thinks about FHIR. Is FHIR like the TEFCA for data standards?
Fire is a good standard, and it will prove to be useful in years to come. People, organizations like mine, like probably everybody's, are finding ways to use it, but at this stage of the market, you're sort of having to force yourself to use fire because as a practical matter, the market really isn't. This is not what you're going to hear from the fire brochure, right? I'm saying fire good, but organizations aren't ready to implement it, and fire's like any other. We shouldn't be starting the conversation with fire. We should be starting the conversation with, what do we need here? What information do you need? How does it need to fit in your workflow? And then if the experts decide that that's the right standard and the right technology to use, great. It'll be useful in years to come, and it's starting to be useful now.
I follow the English Premier League. I don't know how that happened, but my kids probably got me into it.
That's soccer.
And sorry. And the teams all have academies, and you'll have the 18-year-olds will play in the academy, and they'll be brought up to the senior team sometimes, and they'll play, and sometimes you'll get a kid who's really exciting, but they're not ready to go in week after week and play consistently. They get a little bit of substitute time, but you know that kid could become a superstar. Now, on the other hand, sometimes kids that seem really great at 18, at 22, they just never advanced. And I think that's where we are with fire, is that we see it doing some very exciting things. We all probably use it in certain ways, internally in pragmatic ways. Whether it becomes that superstar that fundamentally changes the infrastructures that we use for interoperability, I think very much remains to be seen.
And thank you for not asking about blockchain.
Yeah, I agree. Our community, so before the Health Information Exchange got started back in 2019, they had for 7-8 years previous that the claims exchange, and it was all API based. And I thought really we were going to start with HL7 version 2, which I came from telecom before I jumped into Health Information Exchange. So to me, that's the copper wires of telecom, tried and true, and they'll last forever, it seems anyways. And I really thought our community was going to be poised for fire, and I thought we would transition to Fire Exchange relatively soon, like right now. And even I've opened up, I have published Fire APIs for access into our data, and no one's using it. It's just people aren't ready for it. I think the providers, and I'm talking to EMR vendors, they're probably using it for internal purposes only, and I think that's where it's going to stay for some time.
I want to underscore, if there's technologists in the room, the technology principle behind fire and object orientation, that's absolutely where we're going and need to go. The ability to use health data properly and securely, like you use the internet where there's APIs enabling that, absolutely. And we're making investments and moving our products in that direction.
Right, I don't think anyone has conceptual problems with fire or use of consistent standards or open APIs or any of those things. But again, it's a tool that needs to sit alongside multiple other tools to get us where we're going, despite folks who can't go 5 minutes without saying it and think it's the magic bullet for everything. I mean, I did tweet it earlier, so.
Transport layer technology, which is what I think of it as, is not by itself going to transform the industry.
Agreed.
Right. Other questions?
I have a question about patients' engagement in their healthcare, and there's some talk about portals and consumerism, and I'm involved in as an informaticist and a number of national projects involved with patients' engagement in their care planning. And for a project with NIH specifically engaging patients who are multiple chronic conditions necessarily spread across multiple providers, complex care, and the patient right now is the only individual that understands, if they understand, the dimensions of the care. So I see a real opportunity for HIEs to be not only a portal for that patient to have a single point of contact rather than having them to go to several endpoints and collect it and then figure it out for themselves. But the second part of the question really is going to be then contributing back to the record. Patient-reported outcomes, patient goals, or what they have for the goals for the care. We're doing this on our project right now, but we're working to individual providers, and we don't have a means to share that patient expression of their needs and interests across the providers, and I see an HIE as being really important. And by the way, we're using FHIR for all of that, but it's really, to your point exactly and agree, it's the outcome that we're working on. The outcome is to improve patients' ability to better understand their care planning in order to use the best available standards. But really, patient engagement is my question here, bi-directional engagement.
I totally believe that, in that 5-year trajectory, we'll be talking about smart apps on top of HIE that will enable that kind of.
You said smart apps, right?
Yes, smart
Okay.
apps.
That's a great board game,
And these
though.
guys too. But I have a Oura ring that feeds to an app, and I share that with my provider because women of a certain age have trouble sleeping at night. Right,
But
ladies?
you needed a ring to tell you.
I didn't, but I'm like, why is this happening to me? So I was really concerned with my sleep patterns, and I needed some documentation of that. But sharing this information, I mean, it's API based. You can share it. I think that's more. We kind of have a black box of patient-generated information that will be able to be shared. Standards in that area are very non-conforming at this point. So I think there's definitely some standard work that needs to be done, and that'll come with time. But I think that if we can get patient-mediated or consumer-mediated consent right, there's other things in the patient-generated space with smart app technology that'll be able to bring that information into HIE as well. That's my opinion. I'm the clinician in the room, though.
I agree with you about the 5-year time frame. I do think that between digital health and patient engagement is not something we've done well. When I first got into the space of, we'll call it health data interoperability, if that's all right. Back in like 2004, one of the first projects we worked on was in a relatively tight community. We were using a portal to allow patients to annotate EHR records which were being sent to a hospital. And they were being sent particularly with ambulance trips and for direct admissions. And it was very hard to get people to actually annotate the record. Where it worked, it was very exciting. But I mean, and when I say annotate, I mean, all right, it says I'm taking that medication, I don't take it. That's, I would think, be a very helpful annotation. But sort of try as we may, we've not cracked the code on that at all, and I
If you
agree.
had been using 17-year-olds, I think they would have annotated the shit out of that. So I would say, David, like it's all.
It's a generation away.
It's a generational thing. I think we have two. I'll give you two extremes. So let's use my 17-year-old, right? Who, if it doesn't happen on her phone, it doesn't exist, right? You could talk to her about metaverse, but like it's all on the phone. So she's going to annotate it, and she wants to engage that way, and she wants a televisit, and she will update all of her stuff and probably publish it to TikTok before the doctor gets it anyway. So the whole privacy concept is just out the window, right? And that's what we're going to be living with, right? And so we should think about that as well, whether we're bringing our own biases about privacy and data exchange when the populations following us don't agree. And then you have like my father who passed last year, and I was his care coordinator, and he had 5 different providers who all had different portals. And y'all, this is what I do for a living, and I could not get them to all sync, and I could not get them to all share things. I literally called them and said, like, what's your direct email? And they said, what is that? And I was like, Farzad. Like, what do you mean? It's 2021, you promised me. How can they they don't even know what that is. Anyway, it was a disaster. So, and even if it had been in one spot, he still would have needed me to help do the interpretation. So I'm also wondering, like, what's our goal here? What's the end goal? Is the goal that all the data be in one place? Because then you still have this question of use that I brought up earlier. Who's going to use it? Is my 17-year-old going to use it? Am I going to use it as the caregiver? Is the patient themselves going to use it? Who's going to use it if it's all consolidated in one place? And then the other question for me is, are we ever all going to be that savvy? Or are we going to almost have like I have someone who like manages my retirement funds, right? Like that's what they do. I don't know what that is. I couldn't do that. So I would need maybe somebody to think. I just want us to challenge ourselves to think about whether as a country we're all going to be ready to manage complex medical data, even if it's all in one place effectively.
Something that's going to be very interesting to watch is that the federal government started a couple of administrations ago very determined to increase individuals' access to their health information. And so the combination of TEFCA and information blocking will guarantee that a determined human who wants access to their information, they will get something called access to their information. I have to air quote that because, and I won't name the vendor, but I was at the AHIMA conference recently, and there was a vendor that very artfully presented what an individual will get because the regulations that the federal government has passed require that they implement the ability for a patient, and they showed it, and everybody in the room was thinking like, that totally sucks. No one is going to be able to make heads or tails out of that. And they kind of dropped the mic. And they didn't, they were diplomatically saying, we have done what the federal government has required. Obviously, you can see it's going to do nobody any good, but those weren't the words that came out of their mouth. So you got to start somewhere, I guess. But it's going to be very interesting to watch that over 5 years and see if those federal regulations, policy is a very blunt instrument when you want a very specific outcome. You can't do surgery with oven mitts on. Sorry if that analogy didn't make any sense. But it's going to be very interesting to see where we are in terms of individual access to data in 5 years.
All right, so we are at time.
Again?
And clearly, we're going to be invited back next year. So you can hear the to be continued on all of these. This is like the longest time to wait before the next Netflix version comes out. But please join me in thanking our panel this afternoon.